unfavorable Kelim. And groups number 3, 4, interestingly, doing the same, whether you BRCA mutated, yes or no, it depends on the Kelim score, favorable or unfavorable. So we conglomerate group number 3, 4 based on the interaction between Kelim and BRCA, meaning that it's not a confounder, it's not a result of your mutation. It has actually an interaction between BRCA and the data derived by the Kelim score. From the same paper, just a different presentation of violin graphs of Kelim higher in HRD positive versus HRD negative, and BRCA mutated versus BRCA wild type. How about the predictive value of Kelim in HiPEC? And if I want to have any take-home messages, it's from the following slides. So HiPEC, highly controversive. Some will say highly not controversive. We have RCTs. Some will say we have 8 RCTs. Never mind. Let's discuss what is the value in HiPEC. This paper, again, published in the International Journal of Gynecological Cancer, integrated data from 2 studies, the COV HiPEC 01, only 45 patients of interval cytoreduction, and from KGOG 3042, 168 patients. Please pay attention. Panel number A. Patients with unfavorable Kelim below 1 benefited much from the HiPEC. Median PFS doubled from 10 months to 20 months. If you have a patient she was with favorable Kelim, she did not benefit from the intervention of HiPEC. Of course, it's retrospective. 20 months versus 21 months. Similarly for overall survival, C and D, we can see the same. The patients with unfavorable Kelim benefit much in overall survival, and those with favorable Kelim benefit less. Different representation, we can see that patients with unfavorable Kelim, the hazard ratio of the benefit of HiPEC is 0.42. And those with a favorable Kelim, it's not significant. How about the predictive value of Kelim in giving bevacizumab? Well, why not to give everybody bevacizumab? Well, it might be expensive, it might be unavailable, it might be toxic for patients, GI perforation, GI bleeding, hypertension. And at least where I practice in McGill, we choose very selectively to who we give bevacizumab in each setting. Never mind if it's cervical, if it's ovarian cancer, you can debate on it. But whether we can use this Kelim score to see who will benefit from this bevacizumab. And after validating data from ICON 7, this analysis was published. You can see the names of Benoit Yu in all these papers. This was published at the JCO. So analysis of the GOG 218. 1,600 patients. Panel number 8, the PFS. Patients with unfavorable Kelim benefited from bevacizumab from 5.6 months to 9.1. Hazard ratio of 0.64, significant. Patients with favorable Kelim did not benefit, no statistical significance value, 0.312. And we go for the overall survival, same. Patients with unfavorable Kelim benefit 0.79. Patients with favorable Kelim did not benefit from addition of bevacizumab, 0.74 p-value. How about PARP? PARP, it's more an easy game, but Kelim can be used there as well. And if you have the opportunity to listen to Dr. Caitlin Moore, one of the greatest minds in gynecological oncology, she stated more than once that Kelim for her is the best predictors for PARP than HRD status or BRCA mutation. Let's see the data. This is the data published by Benoit Yu in JCO from the Velia RCT, almost 900 patients, velaparib. Patients with favorable Kelim and BRCA mutation benefited from the PARP inhibitors. BRCA wild type didn't benefit. BRCA wild type HRD didn't benefit. HRP, of course, didn't benefit. When we go to patients with unfavorable Kelim, they did not benefit at all. So Kelim by itself might be a biomarker for PARP inhibitor response. And this is a good explanation. This scatter plot representation of Kelim score on the x-axis and GIS score, genomic instability score, which actually is the phenotype of the mutational of the genes mutated, whether it's BRCA, whether it's PALB2, CHEK2. Eventually, you have the GIS score. genomic instability score. And you see there is a correlation. The higher the GIS, the higher the Kelim, regardless of BRCA mutation. So I'm coming to conclude my presentation. How the hell do you calculate the Kelim? It's open. You don't need to pay for it. You have the website. It's mentioned here. All you need to know is you can also download it to your smartphones. All you need to know is the exact date of chemotherapy and the exact values of your CA-125. And again, you need to have at least 3. This is just a hypothetical patient. I entered the numbers, the dates, and the Kelim score was 1.15. Pay attention not to enter just data, just hypothetical, and to play with it as I did, because eventually they calculate that there is now an ASCO poster presented by Beno Ayu of the usage of Kelim score. So some of the usage is just for our educational content and not actual patients. And with this, I want to thank you so much. Thank you for your kind invitation. And I thank you so much and continue doing great things.
Thank you very much, Gabriel, on an amazing presentation. Thank you so much. So I have some things to remark. You use the word biomarker. It's a different thing that we call biomarker regarding gynecological cancer. Why do you justify to call this a biomarker?
I might dispute you, or I might argue. Biomarker is something that you can measure, something that doesn't change if you change setting, and it either respond or not respond. So some may say that CA-125 is a biomarker, even though it changes. It's not absolutely a solid biomarker. It's BRCA, you either have it or either you don't have it. You either CPS positive, yes or no. And CA-125 is a dynamic. So you're absolutely right. It is a dynamic, but nomenclaturally, some call it a biomarker. Might be just marketing.
No, because it looks as a biomarker because it has a correlate with a clinical outcome. So probably we need to be aware that the word biomarker will encompass more things that we previously thought. I think that is a biomarker. Although it's the result of that algorithm, it works as a biomarker. So thanks for coming up with this interpretation of Kelim score. Is there anyone interested? Juan Sebastián. Juan Sebastián Obando, I have a question for you, Gabriel. No, Juan Sebastián.
Hey,
go ahead.
Good evening, Dr. Levin. Thank you very much for your wonderful presentation. As usual, very clear and very enriching. I have a small question that has, I think, brought up in our tumor boards in the National Cancer Institute in Bogota, and is the moment where we can take the test and we can verify the test within the calculator. If, for example, the patient has received his first chemotherapy on the 1st of June, but unfortunately, due to several external factors, some of the dates where we take the CA-25 level is not necessarily 1 week after that. Maybe it's just 1 day or 2 days after, or maybe even 2 weeks after that. So, and when we look at the curves and when we look at the behavior of this marker, the CA-125, we tend to see that there's a good response since the marker it's basically negativizing, but interpretation is very difficult. Even when you try to put it in the calculator, sometimes you see, or even the calculator tells you it's a syntax error. You cannot interpret those results since the dates are maybe not as strict or not as far away as they recommend. I think it's about 7 days after the chemo administration. So I would like to ask you, do you have those types of problems? How do you manage them? Do you take aside the Kelim score for your clinical evaluation, or how do you interpret those results? What are the dates where we can be more certain that the results will be more easily applied, or maybe we can interpret it as a chemosensitive disease and validate all these findings? Thank you very much.
Thanks, Juan, Sebastian. It's interesting because everybody has difficulties on the day-to-day practice. All you mentioned is 100% correct. Yeah, you can either play with it in the beginning to see how it's manageable. You can go to your retrospective data. You can collect it. We now had a student actually from Colombia. She's now doing her master at our department in McGill, and we published a poster in ASCO about our data from Kelim, and we did not collect Kelim. She went over the files, but we quite have an organization. The patient comes for chemotherapy. We see her one day before for bloods, and then she gets the chemotherapy the next day or the other day afterwards. So eventually we have a good data set. And I think that the more organized you've become, it's absolutely better. And if you have less clinical visits and the days are not actually 21 days between the chemotherapy, between the carboplatinum, you still can use it and see how it goes. I really, really want to encourage everybody who has time or wishes to do some kind of retrospective data to have it look at his neoadjuvant patients. Give it a try. Give your student to try and see if it has any value or whether it's correlated with outcome, with the cytoreduction completeness rate, or with PFS. It takes time. You need a dedicated student, but I think that eventually, if you will look at your data, I am a true believer in Kelim. It doesn't lie. The disease responds. High-grade serous responds regardless of the biomarker of BRCA/NES, of HRD. The Kelim is eventually how the disease responded, as long as you measure it at least 3 times over the 100 days of chemotherapy.
Tengo una pregunta.
Okay, Mark.
Hi, Rene, how you doing? Thank you, Gabriel. It's a very, very, very special talk. Based on this, and there's evidence you showed about 218, icon 7, and your group for your guidelines. Do you wait for the Kelim before give bevacizumab, or you can use bev at starting of the chemotherapy, or you wait for the Kelim to decide? I'm talking about
Thank you.
neoadjuvant therapy. Yes.
Yeah, thank you so much. I will be honest. We are very, very super cautious of using BEV. I hope it will change now that Dr. Ribeiro is in our team, but we have certain constraints in our tumor board decisions. We don't use it much. And if we use it, it's after surgery and after completeness of interval cytoreduction. We rarely use it in the neoadjuvant setting because patients come with an imaging who shows maybe rectal involvement, maybe bowel involvement, and then we say, God, no BEV. And the only time we can implement BEV is after cytoreduction when the imaging is quote unquote clear and we were in the tummy and we saw there's no massive bowel involvement. So regretfully, we don't use it BEV enough for me to wisely answer it. I think it should be done, but I'm constrained in my practice now.
And the other question is, as we know, there is a strong relationship between Kelim and CRS. But have you, in your practice, do you see the same, the relationship with Kelim and CRS, or Kelim with BRCA? Is stronger between Kelim and CRS, or stronger between Kelim with BRCA, for example?
That's another good question. We don't have very good access to HRD testing in Canada, at least in Quebec. It's not free for all patients. BRCA, it takes time until we evaluate. From the abstract we did publish for the patients we do have BRCA, we saw the correlation. So it might be like a biomarker in populations or in states, in areas when BRCA testing germline or somatic is not available due to cost or technical issues. So we did saw a very nice correlation between Kelim and BRCA/NES.
Thank you, Gabriel. Do you anticipate that the Kelim score will be used in future trials addressing therapeutic agents in locally advanced ovarian cancer as a part of the routine in clinical trials?
I will be honest, Rene, thank you for the question. I don't think so. I don't know why, but I don't think so. I think that pharma won't push for it. Pharma wants a true biomarker. Pharma wants a good biomarker that everybody has, or at least most of the population, and easy to validate. I think not. It will only be continued being used by BenYU in retrospective analysis of RCTs, giving us more retrospective data, which makes me, Gabriel, thinks that I'm so smart. But it's all retrospective data analysis, right?
I am concerned about that because the source we got are retrospective, not prospective one. So it is enough available to be taken into account in a prospective trial, evaluating it in itself as a biomarker, or it doesn't work.
Oh my God, if I have the money and the infrastructure, Rene, I would do a study RCT of PARP inhibitors by Kelim. No need to HRD, no need to BRCA, just do Kelim. Give the good chemo, give the good carbotaxol, good doses until toxicity, hopefully not. This is what I would do. And then if it will be positive, just imagine how much many patients more you can integrate into PARP inhibitors as maintenance. This is what I would do. It won't be done.
And from the money would come because they're not an interested party in doing these kind of things.
Yeah.
Rene, I have another question. This is a very, very good point about use Kelim to define a maintenance therapy. But the problem is in adjuvant setting. All you can do in adjuvant setting when the patient has got a surgery, primary surgery.
So
I'm
the
talking
data
about adjuvant setting.
Yep. So some of the data that BenYU used for the Kelim construction is neoadjuvant, and some is adjuvant. Some is absolutely adjuvant.
But something, Juan Carlos.
In our analysis, we did not. What we did in McGill with the Colombian student, we only analyzed neoadjuvant chemotherapy. But this calculator takes into account, it should work also in adjuvant chemotherapy. There it's more tricky because the values should be much lower and should decrease with time. But yes, you can use it also in the adjuvant setting. How valuable its predict value, I cannot really tell you. Or retrospectively, how good it is.
Thank you.
We have two questions in the chat box. First, Emmanuel, and then Jean Carlos. Emmanuel, go ahead.
Good evening, doctor. Nice to talk to you finally, like more or less face to face.
What's up?
It is true that Dr. Benoit Youth is, as you mentioned, a clinical oncologist. So this is a score that was designed by a medical oncologist to guide decisions on medical treatments. Do you think we can incorporate this score in surgical decisions? I mean, we have tumor boards to evaluate patients who are receiving neoadjuvant chemotherapy, and we have more or less clear in the primary setting which patients could benefit from a primary cytoreductive surgery. But in the neoadjuvant setting, it is a little bit more or less tricky scenario because you guide the decision on a tumor board, guided by images and by the ability of the surgeon to say, I could take that disease off. Do you think we can use Kelim to make the decisions to take a patient to an interval debulking surgery, or they may benefit from one more cycle or two more cycle, or they are not fit for a surgery, and you may change the strategy to a palliative setting, or this is a score which is useful for surgical decisions?
This is an excellent question, Emmanuel. I'm not aware of a very, very good data targeting this question. And we actually now were funded at McGill to doing prospective data for neoadjuvant patients, collecting their Kelim, collecting their ctDNA, collecting imaging and analyzing, and eventually trying to see what is the best biomarker or whether there is a combined model. So for now, it's not really, I mean, you can support it or integrate it. Now in tumor board, when a patient have a good Kelim score and somebody wants to do HIPEC, I mentioned the analysis published in the international journal saying, guys, favorable Kelim, she would not benefit from the HIPEC. I don't know it. It's retrospective data. But for now, I use the Kelim in surgical decision as HIPEC. Hopefully in the future, we will know whether she should get another cycle of chemotherapy. Even though now at the ASCO, the Chrono trial was published, whether there is value 3 cycles versus 6 neoadjuvant, nada. But maybe in the future we will know like where is the best timing to do the interval cytoreduction. Not for now.
Thank you, doctor.
Thank you, Gabriel. Juanca, you have a question?
Yes, thank you, Dr. Levin, for this excellent presentation. Juan Mendieta, Gynecology Oncology Fellow at the Instituto Nacional Cancer in Bogotá, Colombia. At our institution, we routinely calculate Kelim during adjuvant chemotherapy. But however, in our world, clinical practice, CA 125 measures are not always obtained at the exact time point recommended by the model. So, how sensitive Kelim to variation in the timing of CI 125 sampling? And is there an acceptable degree of deviation that will not meaningfully affect to its predictive performance?
So from my understanding, thank you for the question, Juan Carlos. From my understanding, it's not that you are categorized to take the CA125 each 21 days, and if not, it's useless. The model was trained on various timing of CA125. Eventually, the formula was created that it takes into time the days between cycles and the days between the cycle and the CA25 measurement. So you can take it and incorporate it into your calculations, into the calculator, online calculator, regardless whether it's like each 21 days, yes or no. You should try it. I try it, and I spoke with Ribeiro about this, that we should start doing it also for our patients routinely to learn how valuable it is, because the data shows it might be valuable. So it's not that you must do it each 21 days. It's okay if you have deviation, 7 days here, 5 days there. She didn't take blood, she just got the chemo. It's okay, from my understanding.
Okay, thank you.
Is there any other question from audience for Gabriel? Okay, Gabriel, again, thank you very much for being here, for sharing your thoughts with us, and hopefully we can have you again in this space or even better in person in the near future. Thank you very much, buddy.
Thank you all for participating.
Muchas gracias a todos por conectarse y nos vemos en un próximo webinar de la Asociación Colombiana de Ginecólogos Oncólogos. Buenas noches para todos.